Hi there, welcome to Ask the Chiropractor, your source for ultimate health, healing, chiropractic, and medical related information. I'm Dr. Adam Rodnick out of Commerce Township, and I'll be your host today. We're here with our two special guests here. We have Dr. Lee.
Yes.
And Dr. Barsoon.
Yes, good morning.
Out of Walled Lake, Michigan. Thanks for joining us today.
Sure, good to be here. Good to be here, yes.
So I wanted to start off asking you, I know that a lot of people have a misconception and think that if they see a neurosurgeon, which I know is your specialty,
yes,
that they should be prepared to just jump right in the operating table. And I know you do a lot of consultations and a lot of working with patients that doesn't necessarily get them right on the operating table. Is that correct?
That's correct. A lot of what we do is conservative therapy. We're trained to do surgery, of course, but we're also trained to do non-operative management. And in fact, a lot of what we do is diagnosis. In reality, maybe 1 out of 10 or 1 out of 20 of our patients actually get surgery. In the area of back pain, for instance, most of the diagnoses are non-specific back pain. I do have one slide I wanted to show of that. If you could just pan over to it. If you look at the causes of low back pain, again, most of them are non-specific. There are a few that are surgical, like spinal stenosis and disc herniations, but even those sometimes are treated conservatively. But the majority of back pain is non-specific and is treated non-operatively, and that's where many other modalities would come into play.
Right, and as you said, even just that little small, this little pie on the chart are the only surgical cases, but even a good chunk of those don't necessarily need surgery, correct?
Not all of those need surgery. Those are the ones that would be an indication for surgery in some cases, and that's not an all-inclusive list. There's been a good study lately called the SPORT study that has indicated that surgery can be indicated with a herniated disc, spinal stenosis, and what's called spondylolisthesis, which is slippage of the bone. And even in those cases, the first thing to try is always conservative, other modalities. But just to give you an idea of how much of back pain, for instance, just in that area, is non-specific back pain, and that would be treated with alternative therapies other than surgery and even medications. This pie chart seems to show that very well.
Really puts it into perspective.
Yeah.
And so what percentage of people, or what number of people would you say that end up having surgery of the total patient base?
Well, it depends on what the diagnosis is. In terms of back pain, in general, it's a small fraction. In terms of diagnosis such as herniated disc, it might be a third of patients that end up with surgery for herniated disc.
So in general, for our audience, as you said, a small percentage of people with back pain end up with the surgery, and that's not just people with back pain, that's people that are already referred to you as a neurosurgeon, that are already another level in, not
right,
just people off the street. So just because someone has a consultation with a neurosurgeon doesn't mean that they're getting ready to jump right on the operating table immediately.
No, and one of the best modalities, in fact, is what you and Dr. Barsoon do, which is chiropractic treatment, spinal adjustment. That's been shown in numerous studies to be extremely effective for neck and back pain. I know maybe Dr. Barsoon can talk about chiropractic treatment and spinal
Absolutely,
adjustment.
and I know that there's another big misconception too, that most medical doctors or surgeons don't work with chiropractors and chiropractors don't work with them, and I know that the two of you guys work very closely with one another. Could you kind of talk about your experience and how you do work with one another so well?
Sure. One of the first things that I realized when I walked into this office was something that Dr. Lee quoted to me about the amount of research that's available on things like chiropractic, massage, yoga therapy, and how it stacks up to the critics and the scrutiny, and how things that are neurosurgical related have a lot less of that kind of study and that kind of research behind it. And we need to know as chiropractors that this is the kind of information that we bring to the people. And at the end of the day, we look at bringing truth to the people, and if they understand how their bodies work, if they understand the truth about what we know about how to treat certain things, especially the most common ailments of men and women these days, which is most likely back pain, neck pain, something related to a pain syndrome, and teach them ways that are non-drug related because of the stacking problems that are beginning to occur with that. But so it's very refreshing to know that we've got this connection and that we have this that we have this inlet to educate people about that. Because at the end of the day, who's responsible for their health and their well-being? The people. And if they don't know, if they don't have good information to back that up, then they're basically moving from ignorance, which doesn't help anybody.
And I always think it's really fantastic to see chiropractors and surgeons working together, where that's really a public perception that they don't. And I hear that from so many people coming into me with that perception, and I work to change that perception because, you know, we do co-manage with so many other different types of specialties and physicians, and we can all work together for the betterment of the patient. You know, not that only I help them, only they help them. It's all about getting the patient well, keeping the patient healthy. And, you know, I tend to start with the philosophy, it doesn't ever hurt to go natural first, drug second, surgery last, and go in that progression as well as we can. A lot of times they have to get to surgery quicker than later. A lot of times that they can stay in natural and not work their way up the spectrum, but never hurts to start in that progression.
Yeah.
Drugs, natural first, drug second, surgery last.
Yeah, and the old saying that if all you have is a hammer, the whole world looks like a nail.
Right, exactly.
And anybody that just uses one modality to treat complicated problems like neck and back pain is really doing, you know, a disservice to their patients. In neurosurgery, we for a long time were driving the ship without a compass, so to speak. We didn't have a lot of good studies to show that what we did was effective. Now, recently in the area of back pain, there's a good study that was done called the SPORT study. It stands for Spine Patient Outcomes Research Trial. And in that study, we do have good evidence that neurosurgery is good for herniated disc, spinal stenosis, and slippage of the bone. Those are three causes of back pain. But when you look at all the causes of back pain, there's been some good studies and guidelines that have been put out by the American College of Physicians and the American Pain Society based on thousands and thousands of studies. And in their recommendations, they list as highly effective and good evidence basis for use of these modalities. They list a lot of different treatment modalities. Chiropractic treatment is listed as having a lot of evidence for its effectiveness with neck and back conditions. Actually, yoga, acupuncture, massage, biofeedback, different types of interdisciplinary programs. These are all areas that have lots of good evidence and research and study. And only, you know, recently, really, in neurosurgery, have we started to see some studies that have shown that what we do is also very effective in very select groups of patients. But for sure, spinal manipulation adjustment chiropractic treatment, along with yoga therapy and massage and acupuncture, are all very effective and have been supported by the literature.
Absolutely. And Dr. Barsoon, let's talk a little bit about some of the research that we do have on chiropractic adjustments. And what are some of the journals that are really popular that we could see some of that research in?
Well, I know that in the Journal of Manipulative Therapy and Physiological Therapeutics, JMPT, that's out of National, they do routine studies, and I know they've done a lot of meta-analysis where they've gone back to look at some of the smaller studies and seen these trends where we're talking about patients that have been either in acute or chronic situations. These types of therapies that educate people on how to do proper lifting, you know, all of this education which is prevention based, as well as first aid and palliative, you know, helping to relieve these symptoms, have been shown to be quite effective. And I want to say that it was the RAND Corporation that did a study many years ago. I mean, it seemed like many years ago when I was in school back in the 90s, but at the end of the day, it basically showed that the level of satisfaction that patients get when they experience chiropractic and some of the more alternative, what are known as alternative methods, have a very high patient satisfaction when it comes out to it. So at the end of the day, the people are the ones that let you know what works and what doesn't. And if they're telling you it doesn't work, chances are it doesn't.
And like I said, some of those journals, like Journal of Manipulative and Physiological Therapeutics, they have hundreds of different studies. So a lot of people have a misconception, again, that there isn't much research on chiropractic.
Right.
Now, it's hard in general for neurosurgery and chiropractic to do some of the studies that, let's say, the drug companies do, where they're double-blind studies. It's hard to do a placebo in neurosurgery.
No doubt.
It's hard to do a placebo adjustment. But there are, as far as chiropractic goes, there are some pretty big, broad spectrum double-blind studies, they have to be really creative in how they design the study. Where what that means, double-blind, is where half the group, let's say, takes a medication, half the group takes a sugar water pill. They don't know if it is the medication that's doing it or not, and they see if there's a difference between the placebo or the fake one and the real one. But again, it's very hard to do that type of a study with a procedure rather than a pill.
Yeah, in neurosurgery, we really don't have that level 1 evidence, because to do that you'd have to do sham surgery, which can't
be a candidate for that, right?
and it has been done in very limited cases, but it usually means making an incision and not doing the surgery, so that the patient feels like they got the surgery, but they didn't. I can only think of 1 or 2 cases where that ever got approved by a hospital to be done. So we don't really have the level 1 evidence that you might have with a medication or some of these other areas.
So let's talk briefly about some of the different conditions. So I brought some models here, and we can talk briefly about maybe a few of the conditions and what some of the approaches are in taking care of them. I know you talked briefly about something called spondylolisthesis or slippage. Maybe we could explain to our audience a little bit what that is and why that's a candidate for surgery in some cases, and why other times conservative things like chiropractic care have fantastic results.
Well, with spondylolisthesis, there is slippage of the bones, and sometimes there's also what we call stenosis, which would be narrowing of the canal around the nerve roots. Now, that has been shown with pretty good study now through the sport study to indicate surgery in some cases. But again, conservative therapy is something that would be tried first before surgery for that condition.
And I know with that condition they grade it too based on how far it slipped forward. About a quarter of the way is grade 1, halfway is grade 2.
Mm-hmm.
Once you're in grade 3 or 4, that's majorly a surgical candidate. But the grade 1s, we do see some great results with those conservatively.
Yeah, and I think a lot of times the body does tend to heal on its own. There is healing that goes on with the help of chiropractic treatment and other physical modalities, including physical therapy and other types of treatments. In the case of surgery, the reason we want to hold off on surgery is the treatment is removal of bone and fusion with screws and rods, which is a big operation and has some risk involved. And again, it is indicated in some cases for spondylolisthesis, but for sure you want to try everything else available before going that route.
And then another buzzword that I know a lot of people hear is the term herniated disc. So let's see if we can talk a little bit about that and explain to our audience what a herniated disc is, a bulging disc is, or even a ruptured disc is.
Do you have one?
Yeah, I sure do.
Yeah. So that we have this lumbar vertebrae, and each vertebrae has a vertebral body. This portion of the vertebrae is the bodies. In between the vertebrae is the disc, which is a cushion. The cushion or the disc can get torn. If it's torn, it's a weak point in the disc. Generally the outer portion of the disc gets torn, which is called the annulus. And in that case, there can be a protrusion of disc material, such as you see here, which then can compress nerve roots that go generally in the low back area to the leg. This again has been shown in studies to do well with surgery, but again, surgery might be a last resort in most cases. I would much rather have myself or one of my family members or one of my patients treated by Dr. Barsoom or yourself before going the route of surgery. And Dr. Barsoom has very interesting ways of treating herniated disc in terms of chiropractic care, which I really rely on for a lot of my patients.
And I should just point out that if you let anybody do that kind of surgery to you, you better trust them.
Right. You can look at that again. You can see the screws and the rods are placed into the bone, fusing the segments together.
Yeah, there's usually and this is only one way to do a fusion, but there's usually pedicle screws that go in to the bone through what's called the pedicles, and then a rod that attaches, holding the vertebrae in place so that you stabilize that slippage. And then, of course, you have to lay down bone to allow it to fuse so that things become solid. And this is an effective treatment in some cases, but in my experience, I prefer to have patients treated initially with conservative, non-operative treatment first.
We talked about that herniated disc, and we'll explain a little bit more where, think of the outside wall, where as it could stretch like this, some of that inside part, think of it more like a jelly donut or a water balloon with like a thick jelly in there.
Mm-hmm.
The more you squeeze it, it has to take the path of least resistance, and it can potentially bulge out to the side a little bit. That's why they call it a bulging disc or a herniated disc, where it's going to move off to the side. And again, if there is a little bit of a rupture, then that material can leak out into and affect the nerve roots or the spinal cord as well.
So when patients present with this condition, usually it's of a compressive nature. Their functional exam will say, I have pain if I sit for a while, and the longer I sit, the worse it gets. Or if I lay down and there's little motion, this allows pressure to build up in those discs. And typically, when I hear that kind of history being told to me, I usually have a good idea that there's some sort of disc irritation. The level of the bulge, the level of the herniation will dictate how severe their symptoms are, but almost always patients will get relief, or if they present with relief laying down on their stomach, it'll tell me that that's relieving pressure as gravity kind of pulls that water balloon or that jelly donut towards the ground, and that kind of relieves some of that backside pressure, which is where most of your pain sensitivity is in the disc. And usually that gives us an idea that the patient will respond well to the conservative measures that we use, like spinal manipulation and spinal decompression therapy. Very helpful.
How does spinal decompression therapy work? Because I've seen a lot of great results with your patients using spinal decompression.
So effectively, it works as sort of like a two-prong approach. If a person comes in and they've got a very hot low back, there's a lot of pain, a lot of sharpness, the decompression actually acts to relieve the compression and creates almost like a vacuum in the center of that disc, which kind of sucks the outside of that jelly donut in towards the center. And that by itself is a very relieving motion, helps to relieve a lot of the muscle spasm that occurs that's guarding against the compression of that disc. And then once that person gets out of that very, very inflamed state, usually within about 4 to 6 sessions we see pretty dramatic results in that for most people. Then the decompression starts working to actually help heal the disc. The reason why most of the discs degenerate over time is because their blood supply is very poor, and they depend on the pumping action of our body's natural motion. And as the disc begins to dry out, or if it gets injured, that exchange of fluid to help nourish the disc, to help exchange the waste material from it, starts to break down also. So the decompression actually helps to move fluid as far as fresh nutrition, fresh blood, fresh oxygen in, and to help the waste material out, so you actually begin to get healing. This is why most patients, once they start to feel better, they notice that their number of relapses are less, their number of the severity of their attacks are much less, and that's when they start seeing the light at the end of the tunnel.
Absolutely. And also this model here, you talked a little about degenerative changes when the disc starts to degenerate, and again, they have very little blood supply, so with that normal motion they get good things like water and minerals and nutrients in, and bad things like inflammation or scar tissue or cellular debris out of the disc. When they're not moving right, it's just like a sponge not getting fluid to it, and it dries out.
Right.
And then what we start to see is the body lays down calcium deposits or bone growth around the edges to stop some of the instability. That's what we call bone spurs, which I know is another common term that people may not know what it means. So here's the difference between, again, the degenerative disc and the bulging or herniated disc here. And so what he was talking about is the spinal decompression therapy, where actually we're opening up the segments, getting healthy motion in there to help pump fluid into this one, or also just help gain space here, so the disc can help to reabsorb a little bit in this one here. And there's all sorts of different tables, machines, manual therapies that can help to decompress the spine. In our office we have some Cox flexion distraction tables, where the table is a machine that actually comes down, pulls the whole lower back open, and stretches out those vertebrae to then allow more normal fluid and normal motion to come in and decompress the spinal discs. And then, so you also mentioned a little bit about some of the symptoms and where you could see relief when we do orthopedic testing and initial examination. We talked about that with the lower back a little bit, and it's very similar with the neck. You know, we'll see people come in and let's say they say, oh, it really hurts unless I do this. And there's certain motions that we can do to help decompress a little bit, and that shows us which part of the nerves are irritated, which segment or which level, as well as another symptom that we see commonly is the numbness or tingling. You know, we see people come in all the time that may say, I have numbness and tingling just in these 2 fingers, or just in these 2 fingers on the outside. And that really helps us to determine which segment it is, where we may need to have an X-ray, an MRI, imaging, things like that as well.
Yeah, I think the key in any evaluation is coming up with a diagnosis. And so the first thing you're going to have to expect as a patient always is a diagnosis. That's what the chiropractor or the physician always needs to arrive at, which is going to involve taking a good history, doing a good examination, maybe doing x-rays, and possibly an MRI scan, sometimes other studies. But to just have a diagnosis of back pain or neck pain and then to receive treatment is not always the appropriate pathway. You need to have, like Dr. Rodnick said, evaluation leading to some type of specific diagnosis.
And so how important would you say that something like imaging is? And we've seen a lot of advances in imaging within the last couple of decades. Now things are digital, it's a lot easier to do it. How important can imaging be? And a lot of people don't really understand maybe the difference between an X-ray or an MRI or a CT scan. Maybe if you guys could help explain that to our audience.
Well, the imaging is only helpful as something that complements your history and your exam. And in some cases we don't order any x-rays or MRI scans. It depends on what we hear from the patient. If it's, for instance, an older patient that may have been receiving steroids in the past and has fallen and now has severe pain in the thoracic area of the back, one of my thoughts at that point would be a compression fracture. Maybe one of the vertebrae has gotten weakened over time because of osteoporosis and use of steroids, and I am concerned that maybe one of the bones has compressed. That can be treated very effectively with a procedure using a needle called kyphoplasty, and that's something I may want to diagnose early, and in that case I'm probably going to get an x-ray. And with that condition, the thoracic vertebral body compresses, and sometimes compresses down to the size of a pancake, just from simple trauma, not even really a serious trauma, and the patient can have severe back pain. That can heal on its own, but sometimes it's better to do the kyphoplasty, which again is a needle procedure that can make a lot of difference. So in that situation, I'm going to want an x-ray early on, and maybe even an MRI scan if the changes are subtle. In other cases where somebody may have a back strain and a workplace injury, and it's more of a muscle pain, soft tissue injury, I may not order any films. I'd be very interested in referring that patient to Dr. Barsoom for treatment, because he can oftentimes make them better, but I probably wouldn't necessarily get an x-ray or an MRI scan in that case.
Right, most of the time x-rays are not very helpful in determining the reason for their lower back pain, you know, and I think it was either Mayo Clinic or Johns Hopkins that determined 98% of low back x-rays were pretty much useless in determining the cause as well as a viable treatment plan for the patient. So a lot of people were radiated for nothing.
So you talked about the compression fractures here, and you said a lot of times you may see that in seniors. So why would something like this be more common in a senior than it would be in, let's say, a younger individual?
It's mainly due to osteoporosis. Sometimes we see compression fractures with tumors, but the majority of patients that have compression fractures have osteoporosis, and that takes time to develop, and is more common in women. Also more common in people that have received steroids on a chronic basis. So it takes time to develop osteoporosis and weakening of the bone, and so it tends to occur primarily in patients that are older.
And not necessarily from a big trauma. They may have just fallen down, and something like that could happen. When we see it in younger people, a lot of times it's, let's say I've seen this a dozen times, where someone was, let's say, working on a roof. They fell off the roof, landed on their feet, and such hard compressive force caused that bone to crush down a little bit. So it is a little more trauma usually with younger people, unless there's some weakening of bone, whether it's from steroids or something else as well.
Yeah, in a younger person, it's going to take a lot more trauma to crush that vertebral body, and in some cases, In a younger person, there will be bone actually projecting back into the nerves, and that becomes more of a surgical emergency. So some compression fractures require open surgery, especially in younger people with major trauma, falling off a ladder or a car accident, where the bone fragments have actually been pushed back into the nerves and need to be removed in order to give the patient normal function in, for instance, their legs.
We have just a couple minutes left, and I know Dr. Brosum, a little bit ago you touched on prevention and patient education. And how important would you say that is for the public, is prevention and patient education, really to be in the know about what's going on with their health?
Yeah, well, at the end of the day, that's really what it comes down to. I mean, if people understand what they can do to better protect themselves and realize that it's not necessarily something that's going to take a large chunk of their time. Many of the things that I give my patients to do is really what I call it as their functional home rehab, is stuff that they can do while they're driving, while they're sitting at their desk. A lot of it is during times that they really have no excuse not to be doing it, you know. So you make it very easy. You make the you make the integration of what they have to do. You help them integrate it into their daily lifestyle where it doesn't cause them stress. And if you don't have that conversation with your patient, you won't know if they're actually following through on your recommendations. I remember they told us way back when that expect your patient's compliance rate to be 0. And if you come to the table understanding that, then you'll have a better chance to find out how they learn and how they can better communicate with you. But you must teach them, you must show them how to better protect their bodies from injury.
And I would say spinal hygiene is kind of like brushing your teeth. You know, people brush their teeth at home, then they go into a dentist for checkups. They should do the same thing with their spine. You know, they should do homework with their spine as well. So we have right on our website a couple of videos where we have spinal hygiene exercises and stretches. People can just watch them at home, watch them on their phones, and you know, it's really key to keeping a healthy spine and nervous system is prevention. So that's all the time we have for today. Thank you guys very much for joining us.
Thank you very much.
Great, thank you. It was great to be here. Thank you.
And again, I'm Dr. Adam Rodnick out of Commerce Township, Michigan. This has been Ask the Chiropractor. I'm your host. Remember that God gave you the gift of life, and what you do with that life is your gift back to God. We'll see you next time on Ask the Chiropractor.